I'm talking today to Dr. Floyd Loop. Dr. Loop was born in Lafayette, Indiana in 1936. His undergraduate years were spent at Purdue University, and subsequently he graduated from George Washington University Medical School. That was in 1962. He stayed on there for his general surgery training. This was interrupted by 2 years in the Air Force. And in 1968, when he completed his general surgery training, he moved to the Cleveland Clinic for his thoracic and cardiac training. He subsequently stayed on there on the staff. 5 years later, he became the chief of the Department of Thoracic and Cardiac Surgery. And in 1989, he became the chief executive officer and chairman of the Board of Governors of the Cleveland Clinic Foundation, a position that he holds at present. The reputation of the Cleveland Clinic for excellence in cardiac surgery, low mortality, low complications, was established during Dr. Loop's tenure as chief of cardiac surgery. He's the past president of the American Association for Thoracic Surgery. He was for many years a member of the American Board of Thoracic Surgery. He served on numerous medical organizations. He has been an author or co-author and has contributed 350 or 60 publications, a great many of these concerning the evolution of coronary artery revascularizations, and with the particular importance on the role of the internal mammary artery. So I want Dr. Loop to tell us about his experiences with coronary artery revascularizations at the Cleveland Clinic, and also I wanted to start by telling us about his parents and growing up in Lafayette, Indiana, and your early education.
Well, my father was a real old country doctor, and I used to go around with him to the farms, carry his black bag, and I sort of had a Huckleberry Finn childhood. It was a very innocent time. Wonderful boyhood. I went to Purdue University after high school because it was inexpensive for me. I got a full scholarship. And the reason that I chose George Washington University is that that's where my father had gone to medical school. So I either stayed in the Midwest, attended perhaps Indiana University, which was a very good medical school at the time, or I got out of the Midwest, and I was always seeking something new, so I decided to look at Washington, D.C., and I had an uncle who lived there, and I went to see him, and he said, well, the best way to learn about it is to go and see the dean. And I pointed out that we had no appointment. He said, well, that'd be all right. So we walked in to see the dean, who was John Parks, an old football player from University of Wisconsin, and he was getting ready to go to a commencement. And my uncle said, but this young man wants to go to your medical school, and he'd like to meet you. So he brought me into his office and sat down, talked to me for a while, and then one thing led to another, and I did attend George Washington. Wonderful medical education. Had a great clinical exposure there in medical school. DC General Hospital was the site of a lot of our clinical activities. And I decided to intern there because I liked the diversity of practice. But I was drafted. So you remember the Berry plan. So I spent 1 year in general surgery residency, and then I was drafted into the Air Force. So I thought that if I went to see somebody in the Air Force, a colonel or general, that they could advise me on sites to spend the next 2 years. And they were very affable and talked to me a long time about career opportunities and where I might go to at least do a little surgery while I was in the Air Force. And when I got my orders, it said Laredo, Texas. Now, I have nothing against Texas, but they had about a 25-bed dispensary down there, and I didn't feel too good about it, but I packed my bags and I was ready to go, and the professor of surgery was Brian Blades. And Brian Blades called me in, he said, "Where are you going?" And I said, "I'm going to Laredo, Texas." He said, "No, you're not." And he picked up the phone, and within a month, I was at Andrews Air Force Base. And I was very fortunate when I got to Andrews because they didn't have any general surgeons. So a fellow who was in the same status as I was, had 1 year of surgery, he and I became the general surgeons, under supervision, of course. And we did a lot of surgery over the next 2 years. I did so much surgery in the Air Force that I was given a year's credit in residency. And when I got out and went back to George Washington University, I then started my 3rd year of residency, and the chief residents in surgery, one fellow decided to go back into the Navy, so I became a chief resident in my 3rd year, and consequently, again under supervision, performed a lot of surgery. And I decided at that point to go into cardiothoracic surgery. At first I thought I might be a plastic surgeon, but cardiothoracic surgery seemed more exciting, and seemed like there was more opportunities for research and new procedures. So I talked to Dr. Blades, and I said that I had plans. My plans were to go for research for a year at such and such a place, and to study in England for thoracic surgery, and he listened very patiently to all this. And then he said, "You're not going to do any of that." He said, "You know, there's a new field that's going to start. It's called coronary artery surgery." Now, how he knew this, I have no idea, except that he was friends with Don Effler, but this was 1966, and coronary surgery hadn't started. So he said, "You're going to go to the Cleveland Clinic. You go up there for a year, then you come back with us for a year, and then I want you to stay and do heart surgery at George Washington University." I was just amazed by that, because I had no idea about the Cleveland Clinic. I knew some of the advancements that had occurred in general surgery at the Cleveland Clinic, but I didn't know anything about their cardiothoracic program. But you know how you are when you're a young fellow, you sort of do what your mentors advise. So I drove up there, met Don Effler, Larry Groves, and Rene Favellaro, and that constituted the Department of Cardiovascular Surgery. And so I started as a resident. I spent a year there and realized that I just couldn't learn this new, all these advancements in 1 year, and I asked to stay for a 2nd year. And then I was ready to go back to George Washington University, but the situation there was not right. The cardiologists were not yet doing coronary arteriography even, and I thought, this is not going to be right. So Don Effler asked me to join the staff, and that was in 1970. So,
tell me about Dr. Effler. What was he like?
Well,
What
Effler
sort of
looked like he looked like he came from Central Casting. He was a very impressive man. He was a good surgeon. He had started there in about 1948. Don Effler was actually Brian Blades' first resident, and I think I was his last resident. So there's some continuity there somewhere. But Effler gave everyone in the department vast opportunities. He was a very domineering fellow, but he gave everybody the ability to create new procedures, to operate almost with abandon. We had huge experiences. Even at a very young age, I was able to do well over 100 procedures sometimes in a month. And of course, he let Rene Favaloro develop coronary artery surgery.
Now, Effler had been interested in the Weinberg operation for some time, hadn't he?
Yes, that started when Mason Sones selectively catheterized Weinberg implants that had been done by Bigelow and found out that some of them actually worked. So since there was no direct coronary surgery in the mid-60s, Favaloro actually started out doing work with the Weinberg implant.
Now, is it true that the Mason Sones was a pediatric cardiologist?
Yes.
And
excuse me a minute.
yes. I'm interested in, it was sort of a combination of events, the technology to do cineangiography, I suppose.
Mason Sones was a pediatric cardiologist. And one day in 1958, he was doing an aortogram on a patient, and the catheter inadvertently slipped into the right coronary artery, and they were loading a syringe for a ventriculogram, and they thought the catheter was in the ventricle, and the patient received 20, 30 milliliters of dye into the right coronary artery. Now this was this was an example of serendipity, because Mason understood right away what he had done, and he realized that it was possible to selectively catheterize coronary arteries. But then he worked with the amplification of the imaging system, integrating the motion picture camera with the process, and was responsible for the evolution of coronary arteriography. It wasn't until 4 years later that he published his first 1,000 cases, and nobody believed him because the results were just exemplary. There were hardly any complications. In fact, the American College of Cardiology sent a group of people headed by Henry Swan out to the Cleveland Clinic because they were sure that this was false data. And when they came back, Swan said, it's all correct. Sones knows exactly what he's doing. He gets in there and does it. It's a very slick and quick procedure.
And serendipity also sort of played into the way Favaloro arrived at the Cleveland Clinic, I believe.
Favaloro, of course, was Argentine. He came there as a fellow. He hardly spoke English. He spent a lot of nights and weekends in Mason's laboratory looking at arteriograms. And he did perform the various indirect procedures, everything from talc poudrages to Weinberg implants. And one day in 1967, I believe it was in May 1967, Favaloro performed an interposed graft in the right coronary artery, in the mid-third of the right coronary artery. And Sones studied that patient and found that that vein graft was open. And within a very short time, Favaloro then performed aortocoronary bypass to the right coronary artery. And simultaneously, Dudley Johnson performed aortocoronary bypass grafts to multiple coronary arteries. And they were the two that really popularized the operation.
Without really communicating with each other. It appeared,
No.
It appeared in both places.
That's right.
Yes, at the same time.
Right.
Yes. Now, someone told me once that Dr. Cryle, that the Cleveland Clinic was built on thyroid surgery done by Dr. Crowell, and then it was rebuilt by coronary artery surgery. You think that's
well, that's a
correct
rather
assessment?
that's a simplification. Cleveland Clinic started in 1921. There were 4 founders. Cryle and Lauer were the principal founders. And it's true, Cryle had a huge practice of thyroid surgery, but there was also a great deal of surgery done there. Actually, a lot of pioneering effort in colorectal surgery started there with Tom Jones and then others that followed. And so it was a surgical, the surgical prowess of the Cleveland Clinic, I think, probably was responsible for its early fame.
At the time that Favaloro was there, before the coronary artery surgery, was their cardiac surgery program very modest, or was it?
Yes, it was
Sizable.
comparable to other academic centers that had cardiac surgery. These were largely valve and congenital procedures.
How do you think that Favaloro knew to sort of get interested in the coronary arteriograms and take that up? Nobody else really was looking at that time, do you think?
Well, the experience by the time the late 60s rolled around, the experience in coronary arteriography at the Cleveland Clinic was huge. Thousands and thousands of cases had been performed, so there was a massive library of all sorts of things from coronary anomalies to atherosclerosis. And Favaloro immersed himself into it, and he understood that there was largely a centrifugal distribution of the lesions in the right coronary artery, and that there were proximal lesions in the anterior descending and circumflex. And so these findings were conducive to a bypass operation. I think the question was whether a vein from a leg put into an aortocoronary position would actually stay open, and Mason-Sohn showed that it would. And then, as you remember, the retrospective studies of DeBakey's group showed a vein graft that was open 7.5 years after it had been put in.
But Favaloro, he used an interrupted technique.
Yes.
Was that because his background was more in cardiac than vascular, do you think? Or
I think that he believed that this was a finer anastomosis. Some of these vessels were 1.5 millimeters or so that you had to graft into, and that he didn't want any purse string effect of a continuous suture. So that's why he did it that way.
I visited it sometime about that time, and I thought Dr. Favaloro was a formidable surgeon. I mean, he just sort of, I was a visitor, and he kind of scared me. Was he that way for you to work with when you were?
Well, he was excellent to work with. He probably taught me more about coronary surgery than anyone. He was a very kind man, good teacher, excellent technician, and really cared about his patients. He spent a lot of time with his patients, and he had a huge experience. And I just attached myself to Rene Favaloro, and he taught me, well, he was probably responsible for my career as a cardiac surgeon more than any other figure.
He was an Argentinian patriot also, wasn't he?
Yes. So in the mid-'70s, he went back to Argentina.
Why do you think he went back?
I think he always planned to go back. Yeah, they had no events at the Cleveland Clinic that would cause him to leave. He was very happy there, but he always wanted to go back, and there he duplicated a Cleveland Clinic-like model, the Favaloro Foundation, and was very successful for many years.
What do you make of his death? Why do you think that turned out that way?
I don't know. Yeah. I have no idea. He certainly didn't seem depressed to me. I think there were economic times in Argentina that were not good for anyone, including medicine, and that may have contributed some to it. I believe he also lost his wife a few years before that, but I don't know any of the circumstances.
Now, at the Cleveland Clinic at that time, it was the first cases were vein grafts. When did the internal mammary artery procedures enter into it, and how was all that? How did all that work out? It was recognized the value of the internal mammary artery.
We started at the end of 1970, and our series really took off in 1971. It was interesting that we did not know anything about George Green's work. But the internal mammary artery was such a perfect site that it was simply a matter of detaching it, which we already knew how to do from the Weinberg days, and then sewing it into the various coronary arteries. Of course, most of the early cases were just the left internal thoracic artery to the anterior descending. We used interrupted 7/0 silk sutures to do the anastomosis and restudied most of the first few dozen cases, and they all look splendid. We had no idea that 20, 30 years later they were going to look like the day they were put in.
And then when was it that you published the article that sort of established that that had a huge effect on
That was in
survival?
1986.
Yeah.
And it was originally turned down because it wasn't a randomized prospective study. But Gene Braunwald and John Kirkland helped get that paper accepted into the New England Journal of Medicine, and it was the lead article in January 1986.
You think that changed everybody's thinking at that time?
Oh, I don't know, but I think it lent a lot of credibility to the procedure and the long-term results. And it may have opened the path to wider all arterial revascularization.
Now, when did, in doing valve surgery, at the present time, the Cleveland Clinic does almost half of the cases now are valve patients rather than coronary artery surgery. I assume in 10 years ago, it was not that ratio.
Oh, no, and that is attributed to Toby Cosgrove, who succeeded me. I consider my tenure very successful because I passed it on to someone who could do it better than I did. And Cosgrove built up the valve practice, and then of course he even made it better through various minimally invasive techniques that he pioneered.
Well, tell me about those now. In the future of that, you think is that a real established, significant technique?
Yes. Small incisions are here to stay. There's no question about it. The question is how fast robotics and the port-like approach to coronary surgery and valve surgery will occur, and I think that it will take off pretty fast now. I think that people are getting better and better at it every day. I still wish there was a way in which you could stop and preserve the heart as well as you can in the older extensile exposure days, because then the ports would really come in handy. But I think a lot of people don't believe that, as you know. A lot of people believe that the off-pump methods will suffice. However, I think it gets into technical acrobatics when you have to do multiple grafts through very small incisions off pump. But that's a big controversy, and but people are getting better at it all the time, so certainly the minimally invasive era is here.
Do you think, does the Cleveland Clinic do assisted circulation and interested in the artificial heart?
Oh yes, we have big program. We have a big bridge to transplantation program with assist devices. And we have a wonderful Kaufman Heart Failure Center at the Cleveland Clinic with excellent cardiologists. I might add that the cardiologists, too, beginning with Mason Sones, Proudfit, Sheldon, now Eric Topol, each succeeding department chair has made a better department. And this have remarkable cardiologists which help the surgeons immensely.
10, 15 years ago, I think everyone would say that transplantation was a pretty good procedure, but the mechanical artificial heart will be the answer. Do you think that still holds? Do you think there will be
I think there'll be better and better artificial hearts. For a while, it was sort of like free beer tomorrow. You know, I mean, there'd be a artificial heart was coming soon, but as far as a left and right ventricular assist, it's not quite there yet. But I believe that there will be great progress in mechanical artificial hearts that will work and will be miniaturized.
Yes. Now, tell me a little bit more about Mason Sones. Mason Sones he was a colorful sort of a person, I believe.
Mason Sones was a very hard worker, very bright man, tough, hard drinking fellow. He took great. He became a great friend, and he referred me literally thousands of cases in my early years. I used to spend most early evenings in Sones' lab looking at films of potential candidates for surgery. And Mason was just a wonderful guy. He was a very heavy smoker, though, and he got lung cancer, and that was his downfall.
At one of the times I visited the Cleveland Clinic, he wore just an undershirt.
Right.
In the cath lab, an old man's undershirt, not a t-shirt.
Right.
And always had a cigarette with some kind of a holder. He would
yes
smoke.
That's exactly right.
Smoke during the procedure.
Yeah, well, it was a different era. You know, the connection between tobacco and atherosclerosis wasn't very firm at that point, and so lots of doctors smoked in those days.
Oh yeah. Well, now, of course, everybody is concerned about the stents and the drug-eluting stents. What do you predict will happen with the drug-eluting stents?
I think that the cardiologists will use more stents per patient. They will expand the indications. They use it in smaller vessels, probably eventually in diabetics, older patients. I have no personal knowledge about the elutive stents. I know the European results, but it's not going to take restenosis to zero.
Yes.
I don't think coronary artery surgery is over. It'll take a few generations, I think, before that happens.
I heard some people last night saying that it's all going to be downhill because of the new stents.
Well, we'll see.
Yes. Well, I want to ask you about people who influence your life, and your decision to study medicine, I assume, came through your father and his practice.
I think partially through my father. My mother was a very strong personality. She lived to age 99. She saw the whole 20th century, almost. And she was a very organized woman who spoke many languages, was taught at University of Illinois and then at Purdue. And she was a wonderful influence on my life. I emulated her approach to life, her organization, and much of my drive, I think, also came from my mother. So that was the early years. I had a very good education in high school, college, medical school, very good teachers. I think probably in my career, Brian Blades influencing me to go to the Cleveland Clinic at that time probably changed my life more than anything else. Now, how he knew what I should do, why he took an interest in me, I have no idea. But he and Paul Adkins were both very good friends. Adkins was the professor there under Brian Blades, and I would have joined Paul Adkins in around 1970 if conditions had been right at George Washington University. But the cardiologists were talking about phonocardiograms rather than angiography, and I could see the writing on the wall, so I didn't join them.
So also Favaloro, I suppose.
Yes, and Don Effler, by offering me a job, and
yes.
I had many arguments with Don Effler over the years. He certainly didn't want to retire. You had a mandatory administrative retirement at age 60 at the Cleveland Clinic back in those days, and so Effler did not go kindly, and we had a few arguments at that time, but he was quite a force in American cardiac surgery and ran a very good department. So I remember him quite well.
What do you think is going to happen in medicine as far as the finances, cost, reimbursement? How do you think all that's going to shake out? Are we going to have a single provider eventually, or do you think it's going to continue the way it is now?
Well, I think that we're all going to have to run a lot faster in order to stand still. Productivity has to increase, costs have to go down. Very hard to do that in this day and age with the scientific and technical changes that occur every year. I think as more and more uninsured occur, if there's an economic downturn and if the Democrats get in Congress and in the White House, we could well have a modified universal health care. I would see this as very possible in some time between the next 10 and 20 years, maybe earlier. So I don't think that's a good sign for medicine, but I think America's smart enough not to duplicate a Canada Health Act where there is no private practice at all and patients can't buy insurance. I think it would be more like England, with the more disadvantaged people being subsidized.
Yes. Well, I sure appreciate you taking time to meet with me today and to tell me about the Cleveland Clinic, and especially about the origins of the coronary artery bypass procedure.
One thing you didn't ask me about is how I went from surgery to CEO.
Yes. Tell me about
that. And I don't know whether,
yeah.
I mean, don't put my question on the video when you edit it, but you know, I chaired the department for 14 years and happened to be on the Board of Governors when they decided on a change in the leadership of the Cleveland Clinic. And I had no interest in any sort of administrative job other than running a large department. But the selection process wasn't going very well. And I kept complaining as a member of the search committee about the candidates for the job. And so they finally said, well, if you don't like it, give us a plan. So I gave them a strategic plan. And they said, we want you to be the CEO. And the first year, which was the end of '89 and during 1990, was probably the worst year of my life because I had no administration. We made 50 key executive changes within the first 5 years. And we had to change a lot of the department heads in clinical medicine, and we had to change a lot of the key administrative people. But the financial picture changed dramatically in the first year. And so now I'm heading into my 14th year as the CEO of the Cleveland Clinic. And I'm finally, as we say, resting easy in my harness. But it took a long time, and I wouldn't recommend it for anybody.
Was it hard for you to give up the operating room and the?
Well, I didn't give that up until 1999.
I see.
So I operated for quite a while before I retired from surgery. But Cosgrove had such a good department that I was really doing it just to escape my administrative duties. And I didn't do a large volume, about 150 to 180 cases a year while I was the CEO. And so finally things got too busy. We had so many acquisitions. Our health system got huge, and I realized that I was just taking up space. And I just walked away from it, which I think is the way to do it.
How much longer will you stay on?
I'm in the twilight of my administrative career.
Well, I do appreciate you taking time.
Thank you.
And I enjoyed it very much. So we'll end with that.
All right. Thank you very much.
Good.